Okay, Anil, I'm starting.
Okay.
Yeah. Well, good evening, friends, and we're going to talk today about the fibroids and assisted conception. But before I start, it's very sad to know that one of our dearest friends, Dr. Parag Patil, who was a house surgeon working with me and a very close friend. Last 20 years, we knew each other. A very smiley fellow, and he passed away because of corona infection in Mumbai. And so I think we all also need to be very careful about taking all the care possible and against fighting against this COVID infection. Uh, Parag was just fantastic. He was working on female sexual problems, and he had a dedicated work on that. And he was really going to participate in one of our Sunday seminars. But it's so sad that we just have to adjust to this new uh, conditions put by Corona to all of us. This topic of fibroids and assisted conception it's a pretty vast topic, and we're going to address our clinical issues and try and find out some evidences about the same. And obviously, the first thing is on classification of fibroids, and we go by the FIGO classification. I purposefully put this particular slide and putting that 2.5 as one of the other criteria of fibroids. So we do have fibroids from 2 to 5 FIGO classification, which are at whole myometrial segment, and which we may be putting them as intramural, while the 0, 1, 2 would go as a submucous fibroid, and 7, 6, and 7 would be the subserous fibroids. But let's simplify this a little more further by this Bechdel and Lee classification, I would say. It's very clinically relevant, I feel, and this is what we day-to-day practice. And submucous is the one which is definitely distorting the uterine cavity. Intramural is the one which is not distorting cavity, and it is less than 50% in the serosal area. And subserous is the one which is beyond 50% of the serosal area. And this understanding will simplify what we mean by the submucous, intramural, and the subserous fibroids. I think all of you would be knowing this term fibroid mapping. Some of you could be doing a simple 2D sonography and putting some graphical designs like this, or somebody could be doing a 3D USG. A few institutional people could be doing an MRI as well. What I'm insisting is that before you take a decision for myomectomy or giving conservative and what, see to it that you have done a fibroid mapping properly and you exactly know the number, size of the fibroids and where they are actually compared to the endometrial cavity and the myometrium, and that gives a very wholesome picture, and we can plan the further therapies accordingly. Now, let's jump on management. Now, when it comes to infertility, symptomatic fibroids, like symptoms would be either menorrhagia, dysmenorrhea, or pressure symptoms. Definitely, since she's symptomatic, we would go for myomectomy. Definitely, one would go for a laparoscopic myomectomy, hysteroscopic, or open laparotomy myomectomy, depending on the size, number, the skill of the surgical team, and the resources available to that person. Obviously, everybody will take enough care to have adhesion prevention there. They will like to restore the normal anatomy and will keep themselves away from the tubes and ovaries so that the fertility can be preserved very well and she can chase fertility, a good fertility prognosis. Well, is there any role of medical therapy? And that's pretty evolving. I'm not going to talk a lot about medical therapy, but I would definitely forward a paper to all of you, which will by Jack Dones, and really giving very good information about the medical therapy when it comes to even symptomatic fibroids. And this is what we come across in our practice, that is infertility with asymptomatic fibroids. And there is a general consensus about a few management protocols there. I think all of you will agree with me that we will be doing if you find a submucous myoma, definitely that will affect pregnancy, will cause miscarriage. And that is something which you will attempt to do a hysteroscopic myomectomy. And depending upon your skill, you would plan the hysteroscopic myomectomy in one sitting, two sittings, bipolar saline hysteroscopy, or a monopolar hysteroscopy. That's all the endoscopic game which you will follow. Is there evidence that a hysteroscopic myomectomy will make a difference to pregnancy? Yes, Pritz et al. In 2009 in their presentation in Human Reproduction, they said that the risk ratio of pregnancy improvement is by 2. So definitely it makes a difference as far as the pregnancy outcome achievement. This is a definite consensus. And the common question asked by all the clinicians would be, what is a time interval from hysteroscopic myomectomy to an IVF cycle. So after how many days of myomectomy you should do an IVF cycle. And this is one study published in 2012 by Lee Mayer et al. And they divided into two groups. The patients who underwent IVF cycle before 90 days of completion from the surgery, and the ones who went for a pregnancy IVF treatment after between the 91 and 365 days. Now, when you look at the pregnancy rate and the live birth rate, well, from the p-value point of view, it's not significant. Definitely, that is there. But I think when it's such a small study, every pregnancy is so very important for us, and definitely it says that if you do plan an IVF cycle beyond 90 days, probably you will be getting that one extra pregnancy. It looks like that from the figures which is portrayed. So that the 3-month thing follows in hysteroscopic myomectomy as well, that post myomectomy will wait for about 3 months and then you can plan the IVF cycle. Now let's come to this dilemmatous condition of intramural fibroids. It's not that easy as the submucous ones. But again, there is a consensus that most of us will agree that if you find a fibroid beyond 4 centimeter, that will definitely affect the pregnancy rates and one would go for a myomectomy. And if there is a proper subserous fibroid, that probably is affecting the pregnancy and one would not go for a myomectomy for a fibroid, which is that. So again, you have this cutoff of initially it started with 5 centimeter and now the paper is on 4 centimeter, which will the pregnancy rate, so intramural fibroid, and that you would go for a myomectomy. Then the new debate starts is about the intramural fibroids which are less than 4 centimeter. When should we remove a fibroid? Should we remove 3, 2.5, 2, or should we just remove every myometrial fibroid which we see in our practice? Well, we're just going to try and answer this question and find out evidences about this particular issue. Now, let's look at the uterine wall thickness. This is the normal uterine wall thickness on sonography. And believe me, most of our radiologist colleagues, and neither we ourselves, we don't report the myometrial thickness. You would definitely consider that if you're facing fertility, whenever you do a transvaginal scan for your antral follicle count or the primary scan when you're doing on day 2, day 3 of the cycle, please report the myometrial thickness. Very easy to report it, and generally it's about less than 2 centimeters or around 2 centimeters. But the moment it starts going beyond 2.5 centimeter, number one, your chance of assisted conception pregnancy will come down. Number two, probably there is a reason for that, and myohypoplasias could be common with adenomyosis or fibroid, and that would be affecting the pregnancy rates. So you should report what is the normal myometrial thickness when it comes to a standard reporting pattern of any transvaginal sonography. It is the myomectomy effectively enhances the natural pregnancy and especially the larger ones. And what is the limit between the harmful and unremarkable fibroids? So we are just debating here about 4 centimeter and less than 4 centimeter, and we are saying less than 4 centimeter could be probably unremarkable fibroids. And by saying about centimeters, we are just limited by the geometric classification alone. And we just debate amongst ourselves about the measurement. This particular fibroid and this measurement I will do, I will not do, etc. But what about the general inflammation it causes in the endometrium and the uterus? What about the HOXA10, the homeobox genes expression that is decreased with the presence of fibroid? There is venous ectasia. What do we mean by venous ectasia? The myometrial fibroid, when the intramural fibroid which is there are straight vessels going from the serosa to the junctional zone, and these straight vessels will be go away from each other moment there is a fibroid which is developing, and that will press on the veins, and this will give rise to some amount of varicosities on the endometrial aspect of the fibrosis, and that is a venous ectasia, and that varicosity will cause some amount of ischemia, and that endometrium probably may be a little malfunctioning. What about the junctional zone integrity in the presence of fibroid? All these things need to be considered, and not just the geometric classification and the sizes of the fibroid in doing the decision making. So I think we come at a consensus that submucous will remove and more than 4 centimeter will remove, but what about the smaller sizes further? And this is one study in 2014 by infertility study by Jan et al. And he did a retrospective cohort study which was there, and he came out that when the woman has the largest fibroid, a single fibroid which is less than 28 millimeter, or sum of multiple fibroids less than 29 millimeter, they did not have an impact on the clinical pregnancy rate when it came to an IVF ICSI cycle. But intramural fibroids beyond 28 millimeter impaired the delivery rate. The live birth rate was less. So now we have another geometric measurement there, that something less than 28 millimeter or something we may not touch, or beyond that, and between the 28 millimeter to 4 centimeter, again, probably it will affect our pregnancy rate. But then we are advising myomectomy. Do we have, what information we have about the impact of myomectomy on the pregnancy rate? Will it really improve the pregnancy rate when it comes to intramural fibroids? There are very few studies available. And again, in the last decade, Pritch et al. In 2009, he said the clinical pregnancy rate was the relative risk was 3.75. The risk is impressive, but the confidence interval is 0.4 to 30, and that's crossing 1. So definitely this is not significant at all. So whether your myomectomy really improves the pregnancy outcome is something which is not very significant, and still we keep advising myomectomy. And that's what this was a story in the last decade. So evidence is not sufficient for the removal of intramural fibroid just to improve the pregnancy rate. See the deficiencies in the practice what we do, and this lack of evidence is because the way the studies are constructed, and we'll come to that. Uh, so what are predictors of reproductive outcomes when you do a myomectomy for intramural fibroids? And in this publication, they say younger women will definitely have a better outcome. And when you have a large fibroid, when it is beyond 7 centimeters, if you do a myomectomy, a pregnancy outcome would be better. And then the smaller fibroid. The moment you do multiple smaller fibroid removal, probably you're injuring the uterus too much, and your pregnancy rate could go down. Again, whether you have entered the cavity at the time of myomectomy or not is also plays a role. It plays a rather major role, because it's very significant that the ones where you have entered the cavity, the pregnancy rate is as low as 2.8, 9.8 in this particular study compared to 28. Again, the N number is small. I think this is a nice study. This is very recent publication in 2007. And this is by Dr. Vima Karti, and she published in RBM Online. And this is a nice study wherein they compared the IVF and ICSI outcome in a group of patients who had fibroids and underwent that therapy, post-myomectomy IVF ICSI, and normal patients undergoing IVF ICSI. And now one would wonder why the fibroid patients were taken off IVF ICSI. And they explained the whole procedure of need of myomectomy, the improvement, etc. And probably a lot of them had different reasons, other reasons also, like oligospermia, associated endometriosis, etc., which made them go for IVF cycle without doing a myomectomy. So that was a good consent was taken about it. And look at the ongoing pregnancy rates. The ongoing pregnancy rates are, when it comes to group A, that is the fibroid group, that's about 18.5. When it comes to group B, that is the post-myomectomy, there's suddenly a pregnancy rate just 33%. And in the normal group, it's about 27, 20%. And definitely the live birth rate is 97 and 98% post-myomectomy and normal. And this paper definitely tells us that after doing a myomectomy, there is an increase in the pregnancy rate. Now, but don't you think we do come across very commonly pregnancy which is seen with myoma, asymptomatic myoma, as big as 7, 8 centimeter, 10 centimeter myomas coming to us with a pregnancy, and patient is absolutely asymptomatic. You do a first sonography and then you find, well, there is a myoma. All of us have come across this association, pregnancy, which is commonly seen with asymptomatic myomas of varying sizes. And on the other side, we also know that whenever there is a presence of a fibroid, it impairs fertility and pregnancy. So to study this model, I think IVF is a correct model to study this balance. So let's look at all the studies and meta-analysis which has been published when they have done IVF for patients with fibroids or post-myomectomy IVF. So we'll just go through these studies. So we'll just take a small literature review of these intramural fibroids and doing IVF ICSI for them. I think it's always been up and down story. When you go to the last decade, the studies which are published in the last decade, the first studies came with Pritt and Donnays in 2002. And they said, well, there is no negative impact on pregnancy with intramural fibroids undergoing IVF and ICSI. And then till 2010, there were about 4 studies by Baneke, Somagliana, Pritz, and Seish Sunkara. And all of them reported that there is a negative impact on the implantation rate, clinical pregnancy rate. And it was statistically very significant. So all the studies in the last decade said that whenever you have an intramural fibroid, there will be a negative effect on the pregnancy outcome when it comes to an IVF ICSI cycle. Uh, yeah. But there were a lot of poor quality studies. So Mustafa Mitwali and Tinchi from Sheffield, they published this particular thing. They're saying that is another meta-analysis needed. So they just churned the same studies which were studied by say Shunkara and the earlier authors, uh, but they just narrowed it down to studies wherein there was a definite evidence that there is cavity is normal. So there was a evidence that the hysteroscopy was done in all subjects and the uterine cavity was normal. And the Newcastle Ottawa score was very good. That was beyond 7. So they did only the good quality studies they took into consideration. And then they noted, well, there is no negative impact of intramural fibroids on clinical pregnancy rate and IVF. So that is introduced in 2011. So you see the turn it is taking. First it said negative, then first it said, well, it doesn't make a difference, then a negative impact. And in 2011, again, this reanalysis saying that, well, there is no negative impact and of the intramural fibroids. And that's why probably the IVF people kept changing their policies and debating themselves. And why such topsy-turvy studies? Because most of them were underpowered studies, very few prospective studies were there, and poor uterine cavity details were there in the study. Recurrent miscarriages data was missing. Non-IVF data, like, getting pregnancy out of ovulation, induction, IUI, that was all missing. And number of IVF cycles taken to achieve that pregnancy was not there. Again, we must understand the patients with fibroid, not just because of the fibroid, the pregnancies would go down, but fibroid is generally a disease of a fat female of 40. So it's an advanced age, a high BMI, and fibroids are commonly associated with endometriosis, adenomyosis. Few sporadic papers say they're also associated with pelvic infections. And again, postoperative adhesions of the poor quality of a surgery. Now, all that will again decrease the chance of achieving pregnancy. So it has to be, there's so many confounders guiding the pregnancy outcome after an intramural fibroid is diagnosed. And this is the, I would say this is one of those good studies which has taken into consideration the Newcastle Ottawa scale of doing randomized RCT beyond 7. All of them have been prospective studies published by Wang et al. And when they said that, when they included these studies, or 4 studies were there, they did, and they said, well, it is significant. Presence of an intramural fibroid definitely decreases the pregnancy rate. And the risk ratio was 0.7 and the confidence interval was less than 1. So definitely the intramural presence of an intramural fibroid hampers the pregnancy rate. And that was very looked back on. And this is the latest meta-analysis published by Recurrence et al. And this was published, and it also says that there's a 44% lower odds for live birth rate, and this was 0.6% less for the clinical pregnancy rate. So this is convincing enough, I feel, and to say that intramural fibroids are definitely decreasing the pregnancy rate. Still, should we remove all of them, the smaller ones as well? And then if this fibroid is not in the cavity, how is it is affecting the pregnancy rate? And what are the mechanisms of the fibroid which is causing infertility? And what are these factors? So the mechanism which has been described is an elevated amount of TGF beta 3. And they say larger the fibroid, larger is the amount of TGF beta 3. And this is one thing which diffuses across to the endometrium. And it decreases directly the homeobacter gene 10 expression. And this decrease in the gene 10 expression leads to a poor implantation. And this homeobacter gene, if you know correctly, is also associated with endometriosis and adenomyosis, decreasing the implantation potential of the endometrium. So larger fibroid will produce more TGF, and the closeness of the fibroid to the endometrial cavity will have more affection onto the implantation potential. And so there was one study published by Only et al. In 2016 that after the myomectomy, intramural fibroid myomectomy, will there be a positive impact on the gene expression? And they said yes. Well, definitely the gene expression increases. So I think this story of these are the different mechanisms which are biochemical and which could decrease the implantation of an intramural fibroid, which is not distorting, non-cavity distorting, is to be taken note of. This is another thing. The first thing I told you is know the myometrial thickness. And again, in our routine sonographies, we do not say the word the junctional zone appears normal or the junctional zone is distorted. There's so many millimeters of junctional zone thickness. And it is the junctional zone as a gynecologist and fertility specialist, we are highly dependent upon. But it is the junctional zone, which is embryologically related to endometrium. It is a part of the Mullerian system. The surrounding myometrium, embryologically, is nothing but a mesenchyme, which is surrounding that Mullerian system, developing into the myometrium. All the peristalsis you see is in the junctional zone. The endometrium basalis rests on the junctional zone, which has a tuft of radial vessels. Endometrium basalis has the stem cells, and these stem cells are the ones who are forming the endometrium compactum and endometrium spongiosum. All that gets nourishment from the vessels in the junctional zone. So it is so very important. The whole junctional zone is so very important for all of us. Sadly, we don't make a practice to report it in every sonography which we perform. One of the mechanism is the intramural fibroids, which are not distorting the cavity, could be disruption of the junctional zone. So the authors say that intramural fibroid is a misnomer. Let's not call it that way. And it should be rather subclassified as a junctional zone fibroid and an outer myometrial fibroid. Well, that makes sense. So you could have the same measurement, but if it is a junctional zone fibroid of, let's say, 2.5 or 3 centimeter, you probably may remove it because you know that that could be making hampering the junctional zone and in turn the implantation. Well, that away from it, probably you would not touch it. You leave it alone. So all the studies, whatever the meta-analysis which you see have published, they concur the reduced pregnancy rate. And two factors are important now: proximity of fibroid to the endometrium. So if it is a junctional zone fibroid, 2 centimeter or more, remove it. And if it is an outer myometrial fibroid, you need not be very strict with 2 centimeter. You can say about 3 centimeter. Now, think about a type 3 Figo fibroid, which is a junctional zone fibroid, and let's say it is 3 centimeter. I think it's a very, very, very difficult surgery because we go hysteroscopically, endometrial cavity is normal. You go abdominally, well, there's no bulge on the uterine surface, and you really don't know where to take incision. And many a times you maybe have to go with transvaginal sonographic control. You may be doing a needling of the fibroid and then taking incision and so on and so forth. Otherwise, an immature surgeon or not a very expert surgeon will land up into problem doing laparoscopic removal of these small fibroids which are abutting the junctional zone. So it is a difficult surgery, and that's where comes a role. Can we do, if proximity to endometrium is that important, can we not give some medical treatment so that the fibroid regresses away from the endometrium and in turn improves the implantation rate? We're a very logical hypothesis, but we really don't know where any studies are there like that. This is one question asked to us by everybody. Every patient asks you, well, you're planning my myomectomy, what is the risk of recurrence? And I think this is simple to counsel. All our friends from Africa who are attending this, they would say that the African race has more number of stem cell in the fibroid. So a fibroid is made up of muscle cell, fibrous cell, and stem cell. And sadly, our pathologists are not giving us this particular information. So the fibroid which is rich in stem cell will definitely have a chance of recurrence. This woman will have a chance of recurrence. Well, that with muscle and fibrous cell will not. But at present, we know that it is more of a racial thing. And the African race is definitely having more stem cells probably, and their recurrence rate is much, much higher. But then we are advocating laparoscopic myomectomy for almost everything. We just learned that all the sizes, we are just recommending laparoscopic myomectomy. But what are the true risks of doing a laparoscopic myomectomy which can hamper the reproductive outcome? So though it is very common, there could be use of electrocautery. If you use excessive electrocautery like bipolar or monopolar for the fibroid dissection, and that electrocautery will cause a lot of ischemia, and that will induce a lot of fibrosis, and scar will heal by more amount of fibrosis. And there could be poor suturing. See the diagram, it is nicely showing a small defect in the myometrium, which could just collect a hematoma there. And these myometrial layers will not approximate well, and well, that could be an effect of the poor suturing technique, and that can lead to fibrosis. And therein, a spontaneous rupture of the uterus is possible. And a few reviews are published, and some studies are reported a spontaneous rupture of patients, post-myomectomy patients. So this is two questions we must ask each other. Is there a definite indication to remove that fibroid, and does surgery restore the reproductive function? And this is, I think this has to be answered more pragmatically than geometrically. And these are two complications I'm just showing you here. You could have a very thick bowel or ovimental adhesion to the myomectomy site, later on. This is, I would still say, this is a very simple adhesion. You could have a very bad one there, depending upon your suturing technique and how bad the suturing was. And you could have these endometrial defect, not endometrial, myometrial defects with a hematoma, commonly seen in the first 1 month. A few of them will regress, but few of them will persist there, and that can give rise to even a fistula, that can give rise to persistently implantation failures. And we really wonder how to deal with these cases, and probably a lot of these cases get reported as case reports, but not everybody, since it's a surgical complication, not everybody will report it in the literature as well. What about uterine rupture? When it comes to general population, very less, no doubt about it. But this meta-analysis by Clay says that it is 0.75% after a myomectomy. But most of the women underwent elective LSCS when it was a previous myomectomy. This is not probably a true presentation of the rupture cases, but 60% of them underwent an elective LSCS. And another meta-analysis, the incidence was 0.99%. Definitely compared to general population, see, there is quite a high risk of spontaneous uterine rupture. And I'm sure in friend circle, there would be one case reported this way. So excessive bipolar cautery, that would devascularize the thing, post-op hematoma formation. And whenever you're doing multiple fibroid removals, there could be a fibroid, one on the anterior wall, one on the posterior wall, and your energetic endoscopic surgeon will manage both the fibroids in the same time. There will be 4 centimeters on each side, both intramural, both will be managed in the same sitting. You're very happy you did it. But believe me, doing 2 surgeries, 2 injuries to the myometrium will definitely have more scarring, more adhesions, and their outcome could be less. I think this is one area which we need to research. All of us, we need to collect our data of myomectomies with certain criteria there, and how did they progress further? Did they achieve pregnancy, and what was the end of the pregnancy? And this is one data from Indian scenario which will be needed for all of us. What are the pregnancy outcome? Now, obviously, like somebody like me, I'm not an expert laparoscopic surgeon to take care of myomas beyond 6-7 centimeters. So, should I go for a laparotomy? Or if there are multiple fibroids, should I go for a laparotomy instead of doing a laparoscopy? Well, if you go by laparotomy also, you are correct. You just go by the skill of your skill and the patient choices, and the pregnancy rate remains almost the same. So it wouldn't make a much difference whether you choose laparoscopy or laparotomy. Just do a neat myomectomy, give anti-adhesion this to the barrier to the patient, and patient's age, bigger the myoma, all these things have a positive impact, while the number of myoma could have a negative impact on the pregnancy outcome. Uh, now, now let's say you have little small fibroids, which are smaller than 2-3 centimeters. After knowing all these data, we will say, well, surgery appears to be a logical answer. But why not medical treatment? Because medical treatment reduces the size and pushes the myoma deeper into the myometrium, and probably it will go away from endometrium and improve the implantation potential. So ulipristal acetate, now this is one drug I'm sure Dr. Goody wouldn't be using, because it's a banned drug across UK. If, Dr. Goody can correct me here. But this can be used to, this is a one drug which is used very commonly in India, I suppose, and to reduce the size of the uterus. But the laparoscopic surgeon are not in a great favor of this, because ulipristal acetate, whenever you use as a pre-treatment before doing a myomectomy, there is a lot of adhesions, there is more amount of blood losses there. There's a more adherent pseudocapsule. There is fibroid necrosis is also there, and only traction countertraction with a myoma screw will not help. And you may have to use frequent cautery, monopolar or bipolar, to dissect the microfibers and the fibers which are causing those pseudocapsule adhesions. And obviously this will lead to more amount of fibrosis later. And operative loss and blood loss in this group was the same, but earlier author has advised that the blood loss was more and operative time could also be high. And there are no clear operative benefit of giving preoperative ulipristal acetate. Unless somebody has a severe anemia and you need postponement of the surgery, and then probably you could use it. But Donnes et al. Has published a study who says that if there is a type 2 submucous fibroid, you can give ulipristal for a period of 3 to 4 months and see if there is a 50% or more regression in the size of fibroid. If that occurs, probably the patient can chase even a natural conception or IVF with that. Again, something very similar. This is a systematic review on the meta-analysis of pre-treatment with ulipristal acetate. The cleavage plane identification was difficult in 86% of the patient, and that will really put us off using this kind for pre-operatively for the before the myomectomy. I think a lot of us are using ulipristal for non-infertility patients as well, in the women who are coming to us beyond 35 after completion of fertility. I would just put this slide there here for them, that we are worried about the ulipristal causing liver injury. And the sad part is, a lot out of these 5 cases which were reported earlier, in women of about 7 lakh women, 4 of them went for a liver transplant. And that's what makes it very worse. And that's one of the major reasons why this is a banned drug. But Don has published this study, and he says that this is an overstated tragedy. But sadly, when if you go to the data of use of ulipristal till 2020, they have reported one more case of hepatic injury which was irreversible. Though 6 out of 1 million patients, definitely much less than paracetamol causing a liver injury. But this is idiosyncratic. It is not dose dependent. So it is called idiosyncratic drug-induced liver injury, and this is irreversible, and that's what is keeping a lot of European world and British world away from this. Now, another question is: suppose you're using ulipristal as a medical therapy to cause regression of a fibroid, not for surgery. This ulipristal will cause progesterone modulator associated endometrial changes, which is called PAEC. And these endometrial changes will definitely not allow implantation. But Dones et al. Has published that it is reversed generally in 2 months. So you can start safely IVF after 2 menstrual cycles of stoppage of ulipristal acetate. And this ulipristal does not have any long-term effects on the endometrial maturation. This has also been reported in one recent study. What about the pregnancy outcomes? And this is one of the latest reviews published by this youngster from Canada, and about the pregnancy outcomes after fertility preserving treatment in uterine fibroids. And he has reported about 1,575 pregnancies after myomectomies, and about 1,450 were scopic myomectomies, a few were robotic myomectomies. Nice 75% live birth rate, 19% miscarriages, 1.5% ectopic pregnancies, a few MTPs done for fetal anomalies, and one undesired pregnancy. Uh, Placenta accreta and all were diagnosed, but just in about 5 patients. 60% or more patients went for LSCS. About less than 40% went for normal deliveries. And again, the literature does talk about 10 cases of spontaneous uterine rupture. So I think this is all these findings have to be noted by us. And what about ulipristal pregnancies after ulipristal? Very few pregnancies have been reported in the literature. I'm sure there must be many, even because in India we use a lot of ulipristal. There were 12 pregnancies reported of ulipristal acetate, and at least no congenital anomaly has been reported. Since there was such a small cases reported, no meta-analysis possible. And this is a Canadian guideline of management of uterine fibroids in women who otherwise have unexplained infertility. And then it is just individualization, and individualization of management of intramural fibroids. On all these studies, you'll have to individualize the therapy, taking into consideration all the other reproductive factors, especially the ones who have had previous IVF failure for no obvious correct reason, or previous miscarriages after IVF pregnancies. And these are the two, even if the size of the fibroid is small, you would be going for a myomectomy, and probably even a junctional zone fibroid, you would have a very low sensitivity of going ahead with a myomectomy procedure. Well, thank you so much. And there are a few research opportunities here. All the data I went through, all the studies I went through, all of them were long protocols, and all were fresh embryo transfers. I do not know how we can apply these studies and everything straight to our protocols, because we are now doing antagonist protocols. A lot of our cycles are frozen embryo transfer. And the moment you see a fibroid, probably you could be down regulating and then doing a frozen embryo transfer. I really don't know the practices. Everybody would have a different practice. But I think it's time to come together and at least start reporting our data in an Excel sheet and put it together and give it to some research person to analyze and put up that. That's one good research opportunity in India. And again, as I told earlier, the outcome of post-myomectomy pregnancy in Indian women. We do so many myomectomies all over India, so many endoscopic surgeons, and these are two pending evidences for us. Well, thank you so much. And if there are any questions, please do let me know.
No questions on fibroids, my God.
Oh, no, no, no. I have a question, sir. So, what about I missed the initial one, so I don't know whether you talked about the serosal fibroid. Suppose a lady has a cesarean section, right? two,
Yeah.
3 years back. And now she has a big fibroid, which is a subserosal fibroid, almost 24 week size uterus, right? It's a
Hmm.
pretty big, it's a pretty big fibroid, and it has a peduncle.
Hmm.
So, what are the possibilities if we go for the open? Obviously, it is going to be a laparotomy because already 24 week size, and
Correct.
she's a thin
Yeah.
patient, and she's my patient. She came to
Good,
me
good, good,
already
good,
last
good,
week.
good. You're in this forum. You're not on an endoscopy forum. There'll be 10 people saying that I would do it. I would do it.
So, what is the possibility of her if we, go ahead with the laparotomy and it's a subserosal fibroid? There's no intramural component. There's nothing with the endometrial indentation, not at all. So,
Yeah. Thank.
and the because previous is aerial delivery, she has a previous is
Yeah.
aerial.
Yeah, actually, thank you so much for asking this question. This I just missed this point. Number one is whenever you have a fibroid uterus, that fibroid is going to grow by 10 to 15% during the course of pregnancy. So before taking a decision for myomectomy, yes or no, for any fibroid, counsel this to your patient. That is number one. And fibroid will be associated pregnancy affecting the fibroid and the fibroid affecting pregnancy, depending on the size situation. You will counsel the patient. Now coming back to your case of this 24 a big fibroid, a massive fibroid with a normal uterus and a pedunculate, and you want to do a laparotomy, you should do a laparotomy. Nothing wrong. You should do it. Nothing wrong. Now let's complicate this issue further. Let's you have a fibroid which is 6 centimeter, subserosal, and not pedunculated with a wide base onto the myometrium. Let's say it is less than 50% onto the myometrium, not pedunculated. But would you remove just because subserosal? Should we leave it? And it is asymptomatic, or should we remove it? Now that comes a question. That's where you need a very good person who is doing a 3D ultrasound. When you do a 3D ultrasound, and if we start measuring the volume of the endometrial cavity, where the fibroid is situated, if there's a tenting of the endometrial cavity, which tells the tenting of a junctional zone, which tells you that there is a pull of this fibroid, probably you need to remove because that is still causing a junctional zone abnormality. Now, this is very subjective. I do agree. We can't find a study, but this is just a small experience sharing I would like to do with you.
But what would be the chances, because she'll be undergoing repeat cesarean delivery, after how long she can conceive, and what are the chances of,
Ma'am, it's a
because
peduncle.
it's a big peduncle.
That's okay, but peduncle is not going to affect her fertility prognosis at all.
No, it's not about the fertility, sir. It's about the delivery, because she has two scars on the uterus. If there's a
When you
component
have a
of,
peduncle, when you have
no,
a
if there
peduncle,
is a component of when you're saying it is not pedunculated and it is attached to the uterus, then
yeah, yeah, yeah. If you see, if you when you are doing, why there is a spontaneous rupture? The spontaneous rupture is because of excessive use of cautery and fibrosis. There is myometrial apposition is not proper. That's why there's a hematoma collection, and that heals by fibrosis. Okay, and basically poor suturing techniques. When you're doing an open myomectomy, your suturing technique is going to be perfect.
I'm talking about the counseling part, because I'm not going
Yeah,
to
so
do
the chance,
surgery. So,
yeah,
what to counsel patients? So,
chance of
for
rupture is going to be very low. And the literature in the literature has mentioned, as I told you, the Canadian study has mentioned about 10 spontaneous rupture cases. There could be many more which are not getting reported. There could be 10 in India also, which are not getting reported. But we just need to tell them it's rare, but it could be there.
The other thing is, Sachin, uh, I believe that it's very difficult to prove this from evidence. Now, if you have got an intramural fibroid, which is, let's say, 7-8 centimeters large, irrespective how you remove it, you're replacing the entire myometrium at the thickest part of the uterus with a fibrous tissue. And I've seen two ruptures occur spontaneously at 32 weeks. And I think what probably happens is that irrespective of how you oppose this tissue, your fibroid has literally replaced a very strong myometrium that can carry on with pregnancy with a complete through and through fibrous tissue. And I think that's one of the reasons, cases where I think we have to counsel patients and say, see, I've removed your large fibroid. It may be through laparoscopic route or maybe through an open route, but that entire length of the fibroid, right from the top to the endometrial cavity, has been breached. And there is a risk of spontaneous rupture too.
Yeah, actually, Anil, this again goes back to a research opportunity. If even whatever 30, 36 participants here are, they can give us one case where definitely a fibroid which is beyond 10 centimeters was done open or laparoscopically, and what was the pregnancy outcome. I think that would give a good light on this topic. Well, let me go to this question on Ashima Sood, and she's asking, please explain again the effects of intramural fibroid near the junctional zone on fertility. Well, thank you. See, I was explaining basically the importance of the junctional zone in fertility, which I talked about. The endometrium basal is there, the stem cells there, and it's a junctional zone which is of Mullerian origin, and it's a junctional zone which has peristalsis. So all these things make junctional zone to be very, very important and to be studied in detail in every case. Now, how about fibroid? The moment the fibroid is abutting on the junctional zone, there are two possibilities. One, the fibroid will secrete TGF beta, which will which will disrupt the homeobox gene 10 expression in the endometrium, and hence the implantation potential will come down. Secondly, the fibroid will separate away the straight vessels, which are coming from the arcuate to the radial vessels through the myometrium, and that will cause venous compression and cause venous ectasia towards the endometrial side, and that would cause like a varicosity and ischemia there. So these are the hypotheses which has been put forward to that.
My question is, you talked about the ulipristal, right? So what do you recommend? Because I have, used it for my patients, but I've not seen any shrinkage. I've not seen any. So is there any size of fibroid that you should be using ulipristal, and for how long?
Yeah,
And
thank you.
side effects.
Yeah, thank you so much. Firstly, let's ask ourselves a question: why are we using ulipristal? You are using ulipristal in patients who have symptomatic fibroids, probably not chasing fertility. Very few of us would be using it for fertility. Let's talk of the ones who are not chasing fertility. And then symptoms could be menorrhagia or pressure symptoms. If the menorrhagia comes down, we are not worried if the size of the fibroid decreases. Only if the pressure symptoms are there, then we are worried that our fibroid size should come down. So the ulipristal does not have a uniform action on all fibroids. Okay, there will be patients, maybe about 1 in 5 patients, who will not respond but decrease in the size of the ulipristal, because we are giving the minimal possible dose of just 5 milligrams. That is not encouraging. I'm not encouraging you to give a higher dose, please, because again, the liver injury is such a high toxicity there, we wouldn't be doing that. So if the symptomatic relief is there, it's well and good.
In your practice, because you must be using a lot, have
Yeah,
you seen any shrinkage? Because in my practice, I have not seen.
I just share the literature that I do see patients who have not shrunken. So I don't advise them. I don't counsel them that I'm giving this to shrink your fibroid. I never counsel them. I counsel them, I'm giving this to control your symptoms and your problems.
Any
And that
side
you
effect?
don't want the surgery, we will try to avoid the surgery. Nice paper by Donis, giving 3 months of ulipristal acetate, give 4 to 6 months of gap, and again you can give. So you can give intermittent therapy and make her symptom free.
Any side effect of ulipristal regarding bleeding or anything?
And yeah, one or two more things. Ulipristal in few cases, maybe I don't know the exact percentage, need to go through the literature again, causes endometrial hypoplasia. No? And one case of adenocarcinoma has been reported. Okay, so so you will keep a watch. That's why you don't give a continuous ulipristal. If you give continuous ulipristal, chance of endometrial hypoplasia will be high. So you give intermittent shots of ulipristal therapy.
Sachin, Oscar has a question.
Yeah.
Yeah, I just wanted to ask something about uterine artery embolization, because in South Africa, they are promoting it so aggressively. And I would like to know on infertile patients, what is the latest?
Yeah, thank you so much. This particular topic I just didn't include the uterine artery embolization, because it is not to be done in patients who are having infertility and chasing pregnancy. So this is one contraindication for uterine artery embolization. It has the poorest of the pregnancy rates. The miscarriage rate is as high as 30%, and on top of that, it may lead to poor ovarian reserve.
Okay, thank you.
Okay, so that's why uterine artery embolization is something just out and out. It's not to be done. There must be some good corporate hospital there which is promoting that.
Yeah, they are definitely. Yeah. Thanks a lot.
They must have got a new DSA machine.
No, in fact, it has been going on in the UK from 1990s of uterine artery embolization, and I believe that there is a role of a uterine artery embolization, especially in cases where there's a frozen pelvis, and doing a hysterectomy is fraught with danger in in places where you cannot do a surgery, who are medically unfit patients, patients who do not want a hysterectomy. I think we sometimes the gynecologists take hysterectomy very casually, saying that let's remove your uterus. But for a woman, some women feel very strongly about it, and some women do not want a hysterectomy because I think it was difficult to explain reasons, but I appreciate those reasons. And in those cases, uterine artery embolization is there because I work in a hospital where the population is about 30 to 40% of the population comes either from Africa or from the Caribbean. And
you must be seeing massive ones.
Yes, yes. So, in fact, in India, by the time I left India, I'd done about 10 myomectomies, and I did about 50 myomectomies in the first 3 years as a registrar. So that's the number of fibroids we see, and the fibroids which you see across are so complex and so big and so multiple that sometimes surgery is not an option. And I've been, in the IVF unit, I see patients with 2 myomectomies and 3 myomectomies, and they still have fibroids. So I think that's where probably embolization may have a role to play.
Okay, Anil, there is one question by Dr. Sood. No, Dr. Vidya Bharati. When medical treatment is given to decrease the size of junctional zone fibroid, how shrinkage of fibroid will change its site? Yeah, very interesting question. These are all studies done by Donnes, and it's a nicely published report which says about the treatment of fibroids, the present and the future. And when he says that suppose you find a submucous fibroid or junctional zone fibroid, you start with ulipristal acetate, down 2 to 3 months, if there is a 50% decrease in the size, that decrease takes it away from the endometrium. And then he says even the natural conception is possible. What I'll do is I'll forward that paper across. Milind is asking one question about use of mesh after myomectomy. Yeah, I think we all use Interseed after the myomectomy. But I think that's a different talk and different discussion on anti-adhesion measures which should be practiced. But even I use Interseed after myomectomy. Any other mesh, Milind, you can just unmute and tell me if you're using any other mesh.
Hello, sir. I've seen Hafiz Rahman using a mesh after doing Wasada's technique for adenoma. So can that same for?
Okay. So it's a biodegradable mesh.
Yes.
I think I'm sorry, I'm really not much aware about it. I think we should be asking somebody expert like him to, if you could get some more information to share it with us next time. When I really don't know much about this. Okay. And this is one MRI guided HIFU in patient for symptomatic fibroid who is seeking infertility treatment. Does post HIFU had bad effects on endometrium? Well, I'm short of knowledge here because I've not seen any case like this. I think any one of you are working in a big time corporate hospital which is practicing an MRI guided HIFU. I think should be able to enlighten us. But my knowledge is falling short of this particular question, answering this particular question.
It's such a difficult and complex subject. And, the fibroid which you showed, if you go number 3, and those fibroids which are very close to the endometrium, but they're about 1 centimeter or 2 centimeter, you can't approach them through a hysteroscope, and you can't approach them through a laparoscope. And you just don't know. And sometimes they descend into the cavity, and sometimes they don't descend into the cavity. And you just don't know. And I believe that fibroids will move depending on contractions. But it's those I find the most difficult fibroids to counsel and whether to remove. Because you don't know whether you should remove those 2 centimeter fibroids when they can slowly move into the cavity.
Yeah, that's true. And
what I'll do is I'll just share one screen. And this was an observational study on what happens to fibroids after myomectomy. Now, I presented this probably about 2 years ago. And this was, this is almost a paper 2.5 years ago. And they said, well, is synechiae a complication? So it was a prospective study. Laparotomy was done 18 to 45 years, a myoma of more than 9 centimeters. And then they classified is that simple adhesions or complex adhesions. And 117 women underwent a myomectomy. 30 women underwent myomectomy for single myoma, others for a number of cases. And they used an anti-gel, and a diagnostic hysteroscopy was done 6 to 8 weeks later. And what they noticed is that even if you did not open the endometrial cavity, you found intrauterine adhesions. But if you open the endometrial cavity, the risk of intrauterine adhesions was significantly higher. So whenever you do a myomectomy, and this is something quite interesting, because whenever you do a myomectomy and you don't open the cavity, often we say, well, it will not cause intrauterine adhesions. And what this review or research, probably cast an eye is that, will you have intrauterine adhesions even when you open a large, correct a large intramural fibroid, and something which is quite different.
Yeah, I think this is one nice question which has come up here. There are few patients with multiple fibroids who have recurrence of fibroids after myomectomy within a very short period, like 6 months to 1 year. Can you identify these cause cases preoperatively? I think a bit of family history should be able to we should be able to gather. As I told, the histopathologically stem cells we are unable to know, but that's a post-operative. You're asking very specific. Can we identify these cases preoperatively? Just what the literature says is whenever you do laparoscopic myomectomy for multiple fibroids, your recurrence rate is high. When you do by laparotomy, your recurrence rate is low. And it's the smaller fibroids grow at a faster rate. So, I would be little ovarian reserve specific here. Suppose I'm seeing a lady who has a very good ovarian reserve and who has 2 or 3 fibroids. I'm going to plan a myomectomy for her. I will warn her enough. Well, at such a young age, with such a high AMH, you are having these 3 fibroids. Moment we can remove the ones we are able to see, but probably it looks like you have a tendency to develop fibroids, and your AMH is going to push that estrogen into you for a long period of time. So there is going to be recurrence, and that is not in my hand. I cannot pick that up. But that counseling I would do depending upon being very sensitive about the AMH. Suppose the same lady comes at 40, I wouldn't counsel her about recurrence rate and things like that.
One more question. What about using of gonadotrophins and in FET cycle progynova, since we are using again estrogen on these fibroids?
Yeah, Ajit, thank you so much for this question. That's what I said. This is one research. This is a pending evidence here, I would say, because the literature is not talking about FETs in fibroids. But let's logically try and understand. Given the case of adenomyosis and endometriosis, we always give GnRH agonist long and then do FETs. All of us do it. 2 reasons. One, we want to decrease the inflammation in pelvis. Second, we want to improve the HOXA10 gene expression. We don't have any test to know to quantify the HOXA10 gene expression in our armamentarium. The same 2 stories are with fibroid. Fibroid is also a reproductive disorder. Fibroid also has altered HOXA10 expression. Fibroid also causes endometrial inflammation. So I think that story should replicate. Moment you should be practicing a down regulation. The thing is, how much? Not just 1 injection, at least 6 weeks of down regulation minimum. There are studies available now. There's a minimum 6 weeks of down regulation before doing FETs for this. Now you say you will be using Proginova again. That we are compelled to use Proginova. I really don't know whether it will come down and go up again. See, this is a pending evidence. We need to, if we are all practicing, let's say 10 of us are practicing the same thing, let's standardize it. Let's all of us use Zoladex, 2 Zoladex followed by FET, and let's find out what happens to a pregnancy rate in all the fibroids which we see in the community. And probably then we will be able to be a contribution to this evidence.
What about, sir, gonadotrophins on fibroids? Because suppose if a lady undergoes 2-3 cycles and she requires multiple...
Will it? Did I find there was just one study I just came across the analysis of the Amigos data. The Amigos data was all about doing unexplained infertility undergoing IUI cycles. Okay, the P diamond study. And when they did an analysis of that data, they found out what is the chance of fibroid and is it related to a decrease in the chance of pregnancy with repeated ovulation induction and IUN thing. Well, they said that the chance of pregnancy is less, but these patients were also complicated with their BMIs and age, advanced age, etc. Now, your question is whether, like in endometriosis, repeated cycles of ovulation induction will it improve, will it worsen the endometrioma? Similarly, will it worsen repeated cycles of this will worsen the fibroid? No, I don't have a specific answer. I'll have to again do a literature search. If I find something, I'll just
No,
let you know.
Sachin, I have an opinion in this regard. Now, with endometriosis and fibroids, what is the factor that makes endometriosis get worse and what makes fibroids get worse? And it's time. So the longer a patient waits, the chances of recurrence are higher. Now, and this is a discussion which I have with patients often, and I say, well, you've been trying for 2 to 2.5 years to have a baby. And now if I give you 6 cycles of IUI, I risk increasing the size of the endometrium or increasing the size of the fibroid. Now, the evidence is there that IUI tends to increase endometrioma size more than IVF. That's because one is with IVF, you're more likely to have a short rise of estrogen and then it settles down, while with IUI, you have got repeated rise of estrogen. So I think that's a discussion which you have with your patients. Oscar, did you want to ask something?
No, I wanted to ask, if you do a hysteroscopic myomectomy, is there a significant difference about the outcome if you use cold knife or you use energy?
Yeah, I think this is one question to be answered by a perfect endoscopic surgeon. With a cold knife is. See, I don't know what difference it will make, because in my practice I use bipolar saline resectoscope. So I
Okay.
use a loop current, and it's a bipolar saline, so it is less injurious to the surrounding myometrium compared to a monopolar glycine. Then do I use a cold knife? Yes, sometimes the myoma, I would remove about 70-80% of the myoma, and a part of it is inside the, embedded into the myometrium. In such a situation, I do 2 maneuvers. Either use a cold knife, then I change my instrument of 4mm hysteroscope with a cold knife, because then that cold knife is a little stronger than
Oh,
the
yes,
2.8.
yeah.
And then I use the force, push it, the fibroid, and try to scoop it out. That is the one. And sometimes I use a very traditional Hamus maneuver, like, empty the bladder, remove all the instruments, and do a little vigorous bimanual examination, and that fibroid pops out a bit little, and then remove it up. So these are the 2 things which I use in my practice. But I'm sorry, I'm unable to answer your very specific question whether cold knife has a better outcome or a saline has a better. I really don't know that answer.
Okay, thank you.
Okay, I think that was a good discussion.
Well, thank you all. Thank you so much. Anil, what's the next topic? Can we discuss some cases, Anil, next
Yeah,
time?
I've got a case of a woman whose AMH is 2.1 pmol, and I did a random start waiting for the right follicle count, and she's now got 6 blastocysts frozen,
Okay.
and I could present that because it's
0.3 nanograms of AMH from the
yes, yeah. So you know my belief of
yeah. So Anil, let's start. We will discuss over next 2 weeks one of the extremes of ovarian reserve. We'll discuss one case with a very bad ovarian reserve and one with a very high ovarian reserve. Maybe an AMH of beyond 30 or something, 30 nanograms.
Okay, perfect.
So are we going to discuss about the COVID and IVF scenario also? Because we
No,
need.
I'm not an expert.
No, sir, we all are not, because we all are dealing with, but at least we require some guidance to when to restart. Is there any? Because everybody is dealing with COVID.
See,
And today we had a conference of IFS.
I'll
I
tell you
don't
one
know
thing. I'll tell you one thing. The best thing to do is either to download the ESHRE document or to download the British Fertility Society document. And both of them comprehensively explain how to restart a service, backed by evidence. And in fact, ESHRE has an excellent flowchart of how to restart service. And I believe that there were so many seminars on COVID and IVF that I had to switch off my Facebook account for some time.
If it does, we would have attended. Thank you so much,
Well,
sir.
thank you so much, all of you. Thank you very much. Anil,
Okay, thank you.
Oscar. See you.
Cheers.